Good afternoon, dear colleague in Vietnam. I'm Fernandi Moegni from Indonesia, and here I would like to share our experience in using ultrasound, especially in pelvic floor, to detect the pelvic floor muscle weakness. Since pregnancy, before and also after childbirth. So this is my CV, and the outline of this presentation is I would like to share and to explain about what is it called, the levator ballooning, avulsion, and also the urethral hypermobility. How those can be detected in late pregnancy and after childbirth, and after that we could have the take-home messages. So the objective, to know how to detect risk factors, What are those? Both levator hyperballooning, avulsion, and urethral hypermobility. This is very important for pelvic organ prolapse and stress urinary incontinence incidents. And we could detect those by ultrasound since late pregnancy until after childbirth. So this is the problems. What is it called? The pelvic organ prolapse. It's I think it's a very disaster. And also the other one is what is it called? This is stress urinary incontinence. When a lady could not hold urine during the when she cough, sneeze, or doing exercise. Those what we call the pelvic floor dysfunction. And of course, those could happen because of this. This is our pelvic floor, and it could be what is called weakened or damaged during the childbirth. And actually, it's starting since pregnancy. I will show you that during the pregnancy, all of those pelvic floor muscles already being weakened. And the worst case is if those weakened pelvic floor cannot go back to normal after a childbirth. So this is the imaging from ultrasound. This is the pelvic floor, and this is the levator hiatal. And this is a normal one, and you can see which is very different if this during the falsafah, of course, the patient he asked to do a maximal falsafah, and then we could see, how big or how large is the levator hiatus muscle, because of the falsafah. And if the muscle is still good, then it's still normal, less than 25 centimeters square. But if it is already weakened, then when doing maximal falsafah, then we could see that could be this is a very severe ballooning, 52 centimeters square. And this overdistended levator hiatal ballooning is a microtrauma. The worst case, worse than this, is what we call the macro trauma or avulsion. Avulsion means it detached. You can see that if the defect is so severe that it not only overdistended, but it detached also, from the insertion or the origin, at the symphysis pubis, like this. So, according to Professor Diet's study, those two, which is called avulsion, the detach of the levator muscle, and also the ballooning, those two are two independent risk factors for prolapse. It already been determined, since 2011. And also, I would like to share the incidence around the world and in my country. How is the avulsion injury? According to the study from Clara Scheck, this is also from Professor Diet's group. In 2010, the incidence around 13, but it can be nearly 50%. Yeah, in the latest study in 2021. Also, this is a study from Professor VIET's group. Yeah, yeah. So the abortion incidence is in, I think in Caucasian is quite high, but in Indonesia, yeah, in Malay race, yeah, those abortions incidence, it's quite low, yeah, because we can see several studies from our country in 2016. Among Paris women is only 2%. Among prolapse case is less than 10%. Then among symptomatic or severe prolapse cases, most only 10%. But how about ballooning? Yeah, those over the standard. Yeah, according to study around the world, yeah, you can see it's not many. Yeah, mostly around 20%. But in my country, I think it's very high. There is a study from 2014. Among prolapse cases, the rate is around 60%, but actually, if we divide it and differentiate between prolapse asymptomatic, stage 1 is only 30%. But in symptomatic stage or severe prolapse, we can see it's very, very high. And these are numbers among prolapse cases. But how about cases during pregnancy and after childbirth? So this is my latest study, which is going to be published. Yeah, during 30 weeks of gravida, yeah, it's nearly 20% already. I found ballooning already happened, and after childbirth, it's getting twice. Yeah, it's nearly 40%. So there is also a good study here, a quite late study from China, I think. Yeah. So this study going to have association between the hiatal dimension and what is it called, urethral hypermobility. Yeah. So the conclusion about the larger the hiatal area was, then the bladder neck mobility will be much more. Yeah, you can see later. Yeah, so it is have a good correlation or association. Yeah, another study from 2014 from group from Netherlands. Yeah, they also have a result that during pregnancy, women with stress urinary incontinence already had a significantly larger hiatal area compared without. Yeah, and also after childbirth, more caudal and dorsal position of the bladder neck means that more hypermobility of the bladder neck and urethra. So those makes the stress urinary incontinence, of course. So yeah, so this is what we do to have a imaging or do scan of pelvic floor muscle, and then so we placing the probe like this. Yeah, of course, we cover it with the plastic or gloves. Yeah, and then so this is the picture. Yeah, this is the picture we could have. Yeah, this is the symphysis. This is the urethra, bladder, and this is the anorectum, and the vagina is in between, which is quite difficult to see actually, because vagina, there's nothing inside there. What is the vagina, and this is the uterus actually. Yeah. So okay, if we have a 3D facility, then we can have a render volume, yeah, of this levator A9 muscle, yeah, like a V shape or U shape. Yeah, so this is the the urethra and this vagina, and this is the anal. Yeah. Yes. Yeah. This is the picture. We could compare it with the picture. Yeah. This is what is our pelvic floor muscle. Yeah. This is a very good imaging we could have if we have a 3D, 4D ultrasound facility. Yeah. Okay, so what we have for over the standard ballooning microtrauma, yeah. See, yeah, if the patient has to do a maximal falsava, and then we have the imaging, and then we could measure, yeah. So the cutoff point is 25 centimeters square. Yeah, if it is less, then there is no ballooning. If it is larger, then this is of course the ballooning. Yeah, like this patient after the childbirth. Yeah, this is the study from Professor Dietz as well in 2008. And yeah, I could show you. This is what the patient in rest, and then has to be falsava, and then this hiatal area will be getting bigger and bigger, or larger and larger. Yeah, when after the maximum, and then we could freeze, and then we could measure it, whether it is less or more than 25 centimeters square. Yeah. Another way, if we don't have the 3D, and then we could also diagnose the ballooning with 2D. Actually, yeah, this is the way we have already the 2D, yeah, symphysis, urethra and bladder, and this is anorectum, and so this is the posterior of the levator anal muscle. So during the maximal falsava, yeah, we also can measure how large or how is the distance between symphysis and the levator anal muscle. The cutoff point is around 6 cm. Yeah, so like this, if the maximal falsava it's less than 6 cm, then it's still normal. But if like this, it's getting longer, more than 6, then it could be determined as a ballooning. Yeah, this is also a study from group of Peter Dietz. Also, another group from China have a same study, and they also have this all exactly the same. The cutoff point is around 6 cm. Yeah, to determine between non-ballooning and ballooning. Yeah. So I would like to share what we measure from symphysis until here. Yeah, I would like to share. This is in rest, and then doing falsava. See, this is getting larger and larger, and then when the maximum, and then we could measure it. Yeah, how many centimeter? Actually, this we measure the anterior to the posterior of the hiatal. Yeah. Okay, we move to the next one, which is called the avulsion of macrotrauma. Yeah, this is like previously I've already mentioned that this is actually detached. Yeah, so basically the levator anal muscle should be have an insertion or origin in the symphysis pubis. Now, when there is some detach, yeah, this is unilateral detach in right side, and we can see difference between the left side. Yeah, this is from ultrasound imaging, and this is from MRI. It's the same. Yeah, and clinically it's quite difficult actually to see. Usually this detachment, this avulsion happen after a very difficult childbirth, maybe using like forceps or some, and then we have a very deep very deep wound, yeah, here in vagina, lateral of vagina. Then there there might be some avulsion. Yeah, so with ultrasound it's very easy. This is normal, this is unilateral right avulsion, and this is a bilateral. Yeah, left and right avulsion, yeah, with 3D ultrasound. Yeah, this is one of my patients. Yeah, a right side of avulsion. And also Professor Deeds already have a study with a cutoff point of 2.5 centimeters. Yeah, if we have this is what is it called, multi-slice ultrasound. Yeah, so we could see that we could measure it from urethral until this is the most lateral side of the levator anal muscle. Yeah, if it is more than 25 millimeters, this could be diagnosed as an avulsion. If less, then it is normal, still intact. Yeah, like this. So this is the example. Yeah, this is a normal one. If we measure from urethra until the levator anal, then this is less than 25 millimeters, or this is, yeah, this is a bilateral avulsion. Yeah, so right and left avulsion more than 25 millimeters. Yeah. Okay. Okay. Again, if we don't have a 3D, 4D, we could also still diagnose with 2D. Yeah, like this. Yeah. After we placing the probe midline, and then we could tilt it. Yeah. To the right or to the left. Yeah, around 20 degrees. Yeah. So we could have imaging like this. Yeah. This is the muscle. Yeah. This is the puborectalis muscle, and this is the place where it is have a insertion or origin in DF symphysis pubis. Yeah, this is a normal. Yeah, it is stick to the bone, right? Yeah, but yeah, this is a normal one. Yeah, this is the muscle, left and right. Yeah. This is example from my patient. Yeah, and the difference, if yes, this one is a difference. Yeah, we could see there is a black area. Yeah, so this is a detachment. Yeah, or avulsion. Yeah, of the levator anal muscle. Yeah, it's very easy to be determined or to be distinguished. Yeah, this is also example from my patient. Yeah. This is a detachment, yeah, avulsion right and left. Yeah. Okay, so yeah, this is I would like to show, yeah, how we could have that kind of imaging. This is from midline. Then when we tilt to the right, yes, this is the muscle, and then we could ask the patient to contract. Yeah, so we could see the muscle very good. Yeah, this is in the right side, and if we go to the other side, this is the left side. Yes, this is the muscle, and having a better one when doing contraction. Okay, so the third one is about urethral hypermobility. Yeah, already been discussed. This is the urethra when doing Valsalva. If the urethra and bladder is, yes, is moving. Yeah, it is moving much more, so that would be a stress incontinence then. Yeah, so the parameters we could have, there are some several parameters. Yeah, you can see here there is what we call, this is a retrophysical angle here, and then if since before Valsalva and after Valsalva, we see there is a changing of the urethra, and then there is an angle like this, which is a urethral rotation angle. Yeah, so we could also measuring this angle. So basically we usually measuring the retrophysical angle, urethral rotation angle, and also the bladder neck descent. Yeah, so the moving of the bladder neck here. Yeah, since before the distance here and after the maximum Valsalva, then the bladder neck is moving higher than the symphysis here. So here plus here is the distance, what is called the BND, bladder neck descent. Yeah. Yes, and also there is a funneling. Yeah, when doing maximal fossa, if there is a funneling like this, so this is also a typical of stress urine incontinence. Yeah. So there are several studies from around the world. Yeah, this is from Arab Journal. Yeah, they measuring the retrovesical angle and cutoff points around 141 um, degree. Yeah, for retrovesical angle, and there's another study from China, and they have a cutoff point of around 2.5 centimeters for bladder neck descent, and for urethral rotation angle around 45 degrees. And my study with my resident, yeah, this has already been presented in last December, yeah. So this is our measuring in late third pregnancy. Yeah, so there are nearly 30% of women in late pregnancy already have stress urine incontinence. And our cutoff point, yeah, the bladder neck descent is around 1.7 centimeters or 1.8, and the retrovesical angle around 155 degrees, and the urethral rotation angles around 30 degrees. Yeah. Okay, so this is the reference. Yeah, we have the BND. Yeah, if it is like more than 2.5 or 3 cm, retrovesical angle if it is more than this. Yeah, and then the urethral rotation angle more than like 30 degrees. Yeah. Yeah. So yeah, with imaging, yeah, of course, those are the parameters. Yeah, this is what is the distance between bladder and symphysis or BSD, and then bladder neck descent will be calculated after the maximal fossa, and then this is retrophysical angle. Yeah, and also the urethral rotation angle later. Yeah. So I would like to share, this is one of measuring by the smart pelvic. Yeah, we have a very good application. Yeah, this is very easy. We do. Yeah, so like this. Yeah, this is the indicator. Yeah, so it's very easy. Yeah, to measure with smart pelvic. Yeah, smart pelvic application. Yeah, we only have to yeah, to point out all of these several points. Yeah, this is S for symphysis. Yeah, place it here, and then after that, continue replacing the bladder neck. Yeah, the urethral, and then this is the urethral proximal. This is retrovesical wall. Yeah, and then after that, okay, we already have the, sorry, yeah, here, and then automatically after we just put all of these points, then the computer or the smart pelvic will count for us. Yeah, those parameters. Yeah, and then we continue it with the patient has to be maximal fossa, and then we can see the moving, yeah, of the bladder again, point the symphysis, and then the this is the bladder neck, urethral, retrovesical wall, and then the computer will automatically counting for us. Yeah, yeah, we can see here, yeah, that the bladder neck descent 2.5 cm, the retrovesical angle 166 degree, and so on, and the others. Yeah, it's very simple. Yeah. Another one I would like to share, this is much easier. Yeah, if you would like to measure the hetero area, yeah, with this smart pelvic, we all we only have to point this only two. Yeah, this is the center of the urethra, and then this is the anterior border of the posterior of the levator ani muscle. Yeah, like this. Yeah, first point, this is the center of urethra, and then the next one is this, and then the computer will calculate automatically for us. Yeah, we already have lots of measurement like the area, yeah, like 20 cm square, yeah, and then we also have this. If the patient we ask to do contraction, when we also can have the measurement of the levator ureter gap, yeah, the 2.5 cm I already mentioned before. Yeah. So it's very easy. Yeah. Okay. So, and there are also some another multi-slice. Yeah. If we have a full multi-slice facility, then we could have a more detail in measuring those. Yeah. This is another sample. Yeah. For yes, symphysis, bladder neck, proximal urethra, and then cervicovesical wall, and then yeah, the most distal, and then save all those measurements, and then ask the patient to do maximal valsalva, and then you can see the movement of the bladder and the urethral. Yeah, it's moving up, but actually it's coming down because it's upside down. Yeah, actually this is going down. Yeah, measure again, symphysis, and bladder neck. You can see there's a funneling here. Yeah, and this is the proximal urethra, retrovesical wall here, and then the computer automatically counting for us. Yeah, retrovesical angle, bladder neck descent, and so on. Yeah, it's very easy. Okay, so my take-home message is so we from ultrasound, yeah, we could have imaging for risk factors for POP and stress urine incontinence, especially with ballooning, avulsion, and urethral hypermobility. Yeah, so with this ultrasound, we could have all of this cutoff point. Yeah, so those cutoff point or those measurement would much help us. Yeah, in determine which patient, yeah, which patient of us that would have a risk factor to have a prolapse and stress incontinence in the future. Yeah, we can measure this ultrasound examination during late pregnancy and then after childbirth. Yeah, so if the patient, yeah, after childbirth, she doesn't have any complaint, yeah, or any problems right now, but if we already have this kind of examination, so this can be prevented. Yeah, we could starting our therapy, yeah, like Kegel exercise, yeah, or we could have several modalities like laser treatment, like magnetic chair or anything. Yeah, so we could prevent the patient to have a severe condition that only can be treated only by surgery. Yeah, that's the goal of us. Yeah, so we could have a good screening for our patient, and then we could ask the patient to do some conservative treatment, something like that. Yeah. All right. So yeah, this is my reference, and after this, I would like to share a video, yeah, to show you how we measure the patient with SmartPerfect application. Thank you very much.